Hi, this is Travis Vesel. I'm a medical instructor in pediatrics at Duke Children's Hospital and an attending in the Pediatric Cardiac Intensive Care Unit. My colleagues and I have helped put together this lecture series for nurses and respiratory therapists as an introduction to congenital heart disease. So my PowerPoint will be the introduction to congenital heart disease, and then there will be several lectures to follow to go into more detail. The objectives of my talk are, at the end of this presentation, the learner will be able to first discuss the prevalence and incidence of congenital heart defects in the United States. Secondly, to explain the differences between fetal cardiac anatomy and blood flow patterns to that of the adult. Next, we'll go through some pertinent patient assessment that indicates potential congenital heart defect in the neonatal patient. And then lastly, we'll go over some common diagnostic tests that are used to detect congenital heart defects in the neonatal population. So first we'll talk about the incidence of congenital heart disease. It's estimated that the incidence of moderate to severe forms of congenital heart defects is about 6 per 1,000 live births, or approximately 1% of infants. It is estimated that this can be as high as 75 per 1,000 live births if you include what, quote, trivial lesions, which do not usually need interventions. So these trivial lesions would be small ventricular septal defects or 2-leaflet aortic valves. The prevalence of congenital heart disease. So for starters, today most infants with congenital heart disease will survive to adulthood. Estimates that there are between 30,000 and 180,000 survivors with complex congenital heart lesions in the U.S., although this is obviously a large range in estimate. So to begin talking about the heart, we'll just review the normal cardiac anatomy. So we'll follow a red blood cell as it goes through the heart and through the body. So on the left, you see a diagram of the heart in cross-section, and on the right side, I've outlined the blood flow through the heart. So blood returns from the body to the superior vena cava and inferior vena cava as the deoxygenated or red blood cell, deoxygenated or blue blood cell enters the right atrium, then crosses through the tricuspid valve into the right ventricle. The right ventricle contracts and pushes blood through the pulmonary valve into the pulmonary artery, which then goes to the lungs, where the blood is oxygenated, then returns from the lungs into the pulmonary veins, into the left atrium. From the left atrium, it crosses the mitral valve and enters the left ventricle, which is the main pumping chamber to the body. Left ventricle contracts and it goes through the aortic valve and sends the oxygenated blood to the body. Once the body receives the blood and removes oxygen, then it returns back and the cycle starts again. To talk about congenital heart disease, you do need a basic understanding of cardiac development. All congenital heart diseases are related to abnormal formation during embryogenesis, which we'll review in the next slide. So there are abnormal formations of venous connections, abnormal formations of the atrial and ventricular chambers, either with formation and or septation of the chambers. There's abnormal ventricular looping, which I'll discuss in the next slide, abnormal valve formation, and abnormalities in the outflow tract formation and or septation of the outflow tracts. So this will just be a very brief primer on cardiac development. So there's 4 pictures in this slide. First is 15 days and 21 days as a fetus, at 28 days, and then at 50 days you have the completed heart formation. So we'll start on the left at 15 days. We've identified cardiogenic precursor cells, which then by day 21 forms into a heart tube, which has the primitive heart structures. So we'll just briefly talk about the heart tube structure. So at the bottom, which is towards the feet of the baby, you'll see primitive right atrium and left atriums, which inflow into a primitive left ventricle, which then goes to a primitive right ventricle, and then through the outflow tracts that are also known as the conotrungus or the aortic sac. So in the third picture, at 28 days, you start to have chamber formation and ventricular looping. So the ventricular looping, you see from the inflow of the right atrium and left atrium, it inflows through primitive valve, AV valve formation into a left ventricle and a right ventricle, which have bulged anteriorly and to the right. So bulging anteriorly and to the right is called de-looping of the ventricles, which is normal. And then the conotrungus and the outflow tracts are over the right ventricle. By 50 days, we have chamber septation. So you have septation of the both the right and left atrium. So now they are separate chambers. You have separate chambers of the left ventricle and right ventricle. You have valve formation of both the mitral and tricuspid valves and the outflow tract valves. And you also have outflow tract formation and septation. So the initial conotrungus is now separated into a pulmonary artery and an aorta. Next, we'll talk about fetal blood flow patterns. So in the fetus of a normally formed heart, there are 3 shunts that are open that close shortly after birth. The first is the ductus venosus, which is labeled 2 on the diagram. The next is the oval foramen, which is labeled in between 4 and 5, which is in the atrial septum, or the top chamber of the heart. And the last shunt is the ductus arteriosus, which is a shunt that brings blood from the pulmonary artery into the aorta. The major difference between fetal circulation and adult circulation is that blood is oxygenated by the placenta. So you have highly oxygenated blood that is coming from the placenta through the umbilical veins into the ductus venosus. And as that highly oxygenated blood enters the right atrium to mix with the deoxygenated blood from the body, it is directed across the oval foramen into the left atrium to bring higher oxygenated blood to the baby's head and upper extremities through the aorta. And the deoxygenated blood coming from the superior vena cava enters the right ventricle and exits through the pulmonary artery and is more directed from the ductus arteriosus to the lower body. Another important thing to know is that as a fetus, all of the blood is oxygenated through the placenta and gas exchange is made through the placenta. So there's very minimal pulmonary blood flow due to a very high pulmonary vascular resistance. So next we will discuss the changes that occur at birth. So the transitional circulation, which is going from a fetal circulation to an adult circulation, starts with the very first breath that the infant takes, as you can see in the upper right corner. As the lungs expand and the infant opens its lungs, you have a rapid decrease in pulmonary vascular resistance. With this rapid decrease in pulmonary vascular resistance, you have a rapid increase in pulmonary blood flow. So now blood is oxygenated by the lungs. Next, infant's umbilical cord is cut and they're separated from the placenta, which has been their gas exchange organ. With this, the ductus venosus closes, labeled 2 on the diagram. As you have increased pulmonary blood flow, you'll have increase in blood flow to the left atrium from the lungs, which causes closure of the flap of the foramen ovale. The last shunt to close is the ductus arteriosus, which normally closes in an infant within 24 hours. For the following days to weeks, as said before, the ductus arteriosus usually closes around 24 hours after birth, but can persist open. But pulmonary vascular resistance continues to decrease over the following 2 months to adult levels. A few basic physiology concepts that are important to understanding congenital heart disease will be discussed here. And we'll get into in a little more detail in the following slides from this one. So the first is that blood flow is inversely proportional to resistance. So if you have a high resistance circuit, such as the systemic vascular bed, you'll have lower flow. If you have a low resistance, such as the pulmonary circuit, you will have higher flow. So the pulmonary vasculature is a lower resistance circuit than the systemic vasculature. So if there is a hole in between them, blood will preferentially flow towards the lower resistance side. Also, the atrial chambers are at much lower pressure than the ventricular chambers, which are the main pumping chambers of the heart, which are under very high pressure. So places that you will see children present with congenital heart disease are in pretty much every part of the medical system. Today, the infants are usually diagnosed with fetal diagnosis, with fetal echocardiography, which can be as early as 12 weeks. However, they'll present in the newborn nursery without a diagnosis, the neonatal intensive care unit, pediatric intensive care units, emergency rooms, clinics, or they may be asymptomatic for life. So patient assessment. First, we'll talk about the physical exam. The main things we look at, which I'll describe in further slides, is skin color, capillary refill time, the quality and strength of peripheral and central pulses, the infant's heart rate, the infant's respiratory rate and effort, infant's oxygen saturations, feeding qualities, and if there's any difficulty feeding, urine output, if there's any organomegaly, such as hepatomegaly or splenomegaly, auscultation, and in particular, listening for murmurs. So it is important to note for patients with congenital heart disease that their presentation and physical exam findings depend on this very specific type of congenital heart disease. However, there are 3 major physiologic categories of symptoms for patients with congenital heart disease. We'll go into each of these in detail in the following slides. The first category is infants with cyanosis. Second category is infants with excessive pulmonary blood flow. And the third major category is infants with inadequate systemic perfusion. It is important to note that depending on the lesion, the patient may only have one of the above symptomatologies or present with 2 or 3 of the above. And we'll go through some examples of each of these. The first major category we'll discuss are infants with cyanosis. There are 2 major causes of this. The first being decreased pulmonary blood flow, and the second being transposition complexes. First, we'll discuss infants with decreased pulmonary blood flow using tricuspid atresia as the example. So as you can see in the diagram, you have normal venous connections to the heart with the superior vena cava and the IVC going into the right atrium. However, you have an atretic tricuspid valve, so no blood flow will go through the tricuspid valve in order to send blood to the lungs. So it crosses the atrial septum, and the deoxygenated blood mixes with the oxygenated blood from the lungs in the left atrium, enters through the only AV valve that is functioning, which is the mitral valve, and then blood is ejected either out the aorta or through the VSD to the pulmonary artery. So these infants classically present with cyanosis, which is due to decreased pulmonary blood flow. And the second kind of infant with cyanosis are what are considered transposition complexes. So the most common one you'll see, a classic one, is called transposition of the great vessels. So as you can see in the diagram, the systemic veins enter the heart normally and bring deoxygenated blood into the right atrium. However, now it will go through the tricuspid valve into the right ventricle and send deoxygenated blood into the aorta to the infant's body, resulting in cyanosis. You'll have some mixing of blood at the atrial level and sometimes with the patent ductus arteriosus, which is one of the fetal shunts that may stay open in this kind of patients. So you have basically two circulations of blood, one with deoxygenated blood going from the systemic veins back out to the aorta, and then you'll just have oxygenated blood circling through the lungs, which is clearly an inefficient system of blood flow. So how will these patients present? So infants with cyanosis usually have the physical exam findings of systemic arterial hypoxemia. It's important to note that cyanosis may not be evident until the oxygen saturation is below 85%, which makes it difficult to visualize cyanosis. Usually these patients are not in respiratory distress. They're comfortably tachypnic with hypoxia. They usually have a normal perfusion exam as there is no obstruction to blood flow to their body. The timing of presentation for these infants can be at birth. However, this may be days to weeks after birth if the ductus arteriosus stays patent. The next major category of congenital heart disease is infants with excessive pulmonary blood flow. There are two major causes for this. First is exclusive left to right shunt, and the second is a dominant left to right shunt with lesser right to left shunt. So first we'll talk about patients with exclusive left to right shunts, using ventricular septal defect as an example. So as you see, the patient's systemic veins enter the right atrium as normal. Blood crosses the tricuspid valve, enters the right ventricle, which then pumps blood to the lungs. Blood returns to the left atrium, enters the left ventricle, which then normally pumps blood to the body. However, if there is a hole in between the ventricular septum, in between the left ventricle and right ventricle, with the left ventricle being a higher pressure chamber, more blood will cross the ventricular septum from the left ventricle into the right ventricle, as it's the lower resistance circuit, and this will result in excessive pulmonary blood flow. The lesion on the right has a dominant left to right shunt. As you can see, the large ventricular septal defect underneath the truncus arteriosus. So as a persistence of the outflow tract and no septation into a pulmonary artery and an aorta. So you have one outflow tract that goes to the body and to the lungs. So you'll have mixing of blood in the ventricular chambers and shunting both left to right and smaller right to left shunt. Infants with excessive pulmonary blood flow have the typical physical exam findings of tachypnea, subcostal retractions, hepatomegaly, poor feeding, and failure to thrive. Tachypnea and subcostal retractions are usually due to excessive amounts of blood in the pulmonary circulation, leading to decreased compliance of the lungs and pulmonary edema. Hepatomegaly from congestive heart failure, poor feeding due to tachypnea, and failure to thrive due to the excessive workload on the heart and excessive energy expenditure. The timing of presentation for these patients depends on the size and location of the shunt, remembering that pressure, resistance, and flow are all interrelated. Therefore, great artery and ventricular level shunts will usually present early, as these are high pressure and high flow lesions, and these usually present either in the newborn period or within the first year of life. Atrial level shunts, which are the low pressure and lower flow shunts, will present later in life or maybe asymptomatic for life. The third major category we will talk about are the infants with inadequate systemic perfusion. There are two major causes of this as well. The first being left-sided obstruction to any obstructions in the left side of the heart, and cardiomyopathy. The image on the right depicts coarctation of the aorta. This is a narrowing of the aorta, which causes inadequate blood flow to the lower portion of the body. So the key physical exam findings for patients with inadequate systemic perfusion are poor pulses. So in the patient with coarctation of the aorta, they will have normal pulses in their upper extremities, however, poor pulses in their femoral arteries and lower extremities. They may have delayed capillary refill due to poor perfusion, tachycardia. Once the patients have significant lactic acidosis, you'll see tachypnea, subcostal retractions, nasal flaring, grunting, and you may start to see decreased levels of consciousness. Usually these patients present early at birth within hours to days as the ductus arteriosus closes. As I stated in the first slide, there are some heart lesions that will only present with one symptom of heart disease, two symptoms of heart disease, or all three symptoms of heart disease. So we'll use hypoplastic left heart syndrome as an example of infants that have all three major symptoms of congenital heart disease. They'll present with cyanosis, excessive pulmonary blood flow, and inadequate systemic perfusion. These babies usually present within hours to days with tachycardia, poor pulses, acidosis, poor capillary refill, tachypnea, retractions, grunting, and cyanosis. And as you can see in the image on the right, depicts hypoplastic left heart syndrome, where you have normal systemic veins returning to the right atrium. Blood crosses through the tricuspid valve into the right ventricle, exits the pulmonary artery to give pulmonary blood flow. And as it returns to the left atrium, you'll see that there is a diminutive or absent mitral valve in a very small left ventricle and a very small aorta. So then blood must cross back over into the right atrium and mixes with deoxygenated blood in the right atrium and exits the pulmonary artery. And these infants are dependent on their ductus arteriosus for blood flow to their body. These infants require surgery near birth. So a few caveats for patient assessment in congenital heart disease. So obviously you must keep an open differential diagnosis for all the patients that you see. So remember that cyanosis and hypoxia can be caused by lung disease, which some examples are atelectasis, infection, mucus plugging, and pneumothorax. Tachypnea, which is a symptom of excessive pulmonary blood flow, can be caused by lung disease as well, or metabolic derangements. So examples of this will be lactic acidosis in a child with poor perfusion, renal tubular acidosis, sepsis, etc. And also poor perfusion may be due to other causes as well, such as poor ventricular function and sepsis. Patients with congenital heart disease are often initially misdiagnosed. So just to give you a few examples of these, so often infants are diagnosed with asthma or reactive airway disease when they actually have a significant congenital heart disease with the left to right shunt, such as a ventricular septal defect. Sepsis and shock may also be misdiagnosis for infants with severe left-sided obstructive lesions. Neonatal respiratory distress syndrome can be misdiagnosed in patients with left-sided obstructive lesions, and also patients with large left to right shunts. And pneumonia and pulmonary disease can often be misdiagnosed for patients with significant cyanotic heart disease, such as the infant with pulmonary atresia. And then hypertension is also a common misdiagnosis for patients with coarctation of the aorta. So the remaining part of the talk, we'll talk about common diagnostic testing. We've already reviewed physical exam, as well as history is very important as well. Chest x-ray, echocardiography, cardiac catheterization, CT angiography, and cardiac MRI. So first we'll discuss the chest x-ray. So when looking at a chest x-ray, we pay particular attention to the heart border and mediastinal shape. So the heart border is the lower part of the chest film, and then the mediastinal shape is the narrowing of the cardiac silhouette near the top of the infant. Usually this is not diagnostic. So we'll go through a few classic images of patients with congenital heart disease. So on the left side, you'll see an infant with transposition of the great arteries, and classically described as an egg on a string. In the middle, see an infant with increased heart size. Increased pulmonary vasculature is seen by the haziness in the lung fields, and this is a child with a ventricular septal defect, so with excessive pulmonary blood flow. And then on the right, you'll see a large heart size and darkened lung fields in a baby with pulmonary atresia. So this would be a cyanotic infant with limitation in pulmonary blood flow. To give a brief historical perspective, back in the around 1950s, in the infancy of care for children with congenital heart disease, diagnosis was often made only with history, physical exam, and a chest radiograph. And the diagnosis was not made until surgical exploration. So this was prior to modalities such as echocardiography, cardiac catheterization, and other new modalities. Next, we'll briefly talk about echocardiography. So echocardiography uses ultrasound technology to create a detailed image of the heart anatomy and function. This is probably the most commonly used diagnostic tool to obtain a diagnosis of an infant with congenital heart disease. This can be done while the patient is a fetus and is with detailed anatomy as early as 12 weeks, and it shows anatomy, function, and flow velocities, which help us estimate pressures within the chambers. So as you can see on the right, you have your right atrium, left atrium, and then a left ventricle and a right ventricle, and then the large blue area in the middle is the outflow from the aortic valve, and then the orange and yellow coloring in the lower part of the photo shows a ventricular septal defect with blood flowing from the left ventricle into the right ventricle. The next diagnostic testing that we'll briefly talk about is cardiac catheterization. So this uses catheters, pressure sensors, radiopaque dyes, and blood sampling to measure and view chamber pressures, anatomy, and blood saturations. And with this information, we can calculate flows through different chambers and outflow tracts, resistances, and overall cardiac output, as well as amount of pulmonary blood flow. As depicted in the image on the right, this can also be a therapeutic intervention as well as a diagnostic test. These are performed by cardiologists. So in figure A, you can see the catheter into the heart. The catheter is currently in the left ventricle. They injected dye, and you can see that the dye and blood flow has gone from the left ventricle both into the right ventricle and out the pulmonary artery, which is on the left side of the image, and the aorta, which is in the middle of the image. Image C shows what's called an Amplatzer device. So they have used the catheters to place this device in the ventricular septum. And as you can see, now blood flows into the left ventricle and out of the aorta with minimal blood flow into the right ventricle, therefore closing the ventricular septal defect. A newer modality is using CT angiography. So using CT scan technology, which uses X-ray technology to obtain images. And you can see in the image below, on the left, that it can be made for 3D reconstruction. So that is a picture of the heart with the ventricular chambers in the outflow tracts in the patient with tetralogy of Fallot. And then also the axial images seen in the bottom right image. This modality is good in that it is non-invasive and is very fast to obtain these images. The last imaging modality that we'll talk about today is cardiac magnetic resonance imaging, or cardiac MRI. Cardiac MRI is very similar to CT scan technology. However, it uses magnets to create its image formation. It can give you very detailed anatomy, and one thing it can do that CT scans cannot do are to show you function of the heart and flow of the heart. And a benefit of this is that it does not have radiation effects on patients. And these images in the bottom right show still frame images. However, technology is available to show the heart beating. So in summary, the incidence of moderate to severe congenital heart disease is approximately 6 per 1,000 live births. Second, reviewing the fetal anatomy, that fetal shunts bypass the pulmonary circulation and direct oxygenated blood from the placenta to the upper body in the developing brain. These shunts close around birth to allow for blood to oxygenate in the lungs and for the child to have a normal adult circulation. Third, is the clinical presentation of congenital heart disease depends on the specific lesion, although they do usually fit into 3 physiologic categories. First being infants with cyanosis, second, infants with excessive pulmonary blood flow, third, infants with inadequate systemic perfusion, and any combination of the above 3. And the diagnosis of congenital heart disease is made with a combination of clinical presentation, physical exam, and various imaging techniques. I hope you have enjoyed this lecture as a brief introduction to congenital heart disease, and enjoy the following lectures created by my colleagues here. Thank you.